Welcome everyone to the June 11th, 2020 COVID-19 clinical care rounds focused on nursing recovery and preparing for a second wave. My name is Richard Hunt. I'm an emergency physician who serves as senior medical advisor at the National Healthcare Preparedness Programs in the Office of the Assistant Secretary for Preparedness and Response at the United States Department of Health and Human Services. The purpose of these rounds is peer-to-peer real-time sharing of COVID-19 emergency department challenges and successes. If I'm recovering from a surge of COVID-19 patients, the nurses and other healthcare providers I want to hear from are those who have the most experience. This is a voluntary public-private collaboration, thanks to the multiple professional organizations who have collaborated. These are not intended to be redundant or replace any organization's initiatives. They are intended to be sharing of clinical experience, not recommendations or guidance. These ECHO clinical rounds you are now participating in are focused on healthcare providers sharing their successes and challenges with other healthcare providers. Thanks to Project ECHO, Dr. Bruce Struminger and his team for the peer-to-peer learning platform we're using for these rounds. Upcoming ECHO COVID-19 clinical rounds currently are all US noon Eastern time. Next Monday, June 15th will be EMS rounds. Next Tuesday, June 16th will be critical care rounds focused on supporting our mental health. Next Thursday, June 17th will be emergency department rounds on COVID-19 and hurricanes. It is self-evident that our nation's medical response challenges are changing every day. While we're still trying to understand how to save lives of those with COVID-19 and take care of ourselves as healthcare providers. We'll continue to work to identify topics for these peer-to-peer learning rounds that are most timely and helpful to clinicians. For the ECHO clinical rounds, we continue to have participants from all states and multiple countries, predominantly physicians, nurses, and EMS clinicians. Thanks to NETEC, the National Emerging Special Pathogen Training and Education Center, for their support with these rounds. These ECHO clinical rounds and NETEC's webinars are complementary to each other. Thanks to the Emergency Nurses Association and the American College of Emergency Physicians in their support of these rounds, these focused on nursing. We continue to receive many questions for each of these rounds, and apologize in advance we're not able to answer all of them. We do select major themes from these questions and hope to cover some of those. We'll be doing crowdsource and polling questions with results shown in real time so we all have the opportunity to learn together. I highly encourage, so that we can learn together, that each of you really do participate in those polling questions and crowdsource questions. With that, I'll turn this over to Dr. Bruce Struminger.
Thank you, Rick, and thank you to our guest presenters today, Kate and Holly, and to our expert panelists who've been so faithful in joining these rounds on a weekly or multiple times per week basis. I've got a few housekeeping items. Just to remind people, there's a Q&A function down in the lower Zoom toolbar. Please put your questions and comments regarding the presentations today and the topic we're discussing in that Q&A space. We'll be monitoring that, and we hope to get to as many of those questions as we can. There is also a chat function. If you've got any technical or logistic issues, put them there. Also, Rick is going to be asking a crowdsourcing open-ended question that we would love your feedback on. And the chat function will be the best place to put the responses to that crowdsourcing question that Rick will get to in a couple of minutes. We are recording this session, and your attendance is consent to be recorded. Thank you for that. Both the presentations today and the recording will be linked to the presentations are linked to the most recent email that went out this morning from Project ECHO. The follow-up emails will both have the presentation links and a link to the recording of today's session. And we will provide a link to our website. There's a special website for these clinical rounds, and all the past PowerPoint presentations and recording links are found there. We're offering CME and continuing professional development credits through the University of New Mexico, where Project ECHO is based. We'll be putting a link in the chat about 15 minutes before the end of the session. And please take advantage of that CME CPD opportunity. It's how we get feedback. There's a short questionnaire, and we really value the feedback you offer to us on how we're doing so we can improve. And we'll be asking what you want to learn about in the future. So that will help guide us as we go forward. And with that, I'm going to pass the microphone to Sharon Van Arsdale with NETEC at Emory to talk about the NETEC webinar series. Sharon.
Thank you so much, Bruce. Good morning, good afternoon, everybody. My name is Sharon Van Arsdale. I'm the Program Director for Emory Serious Communicable Diseases Unit. I'm also the Director of Education for the National Emerging Special Pathogen Training and Education Center. And it has been an honor and a privilege to be able to join Bruce and team every week and multiple times each week to get to talk a little bit about NETEC. So again, we like to collaborate with Project ECHO because these clinical rounds allow us the opportunity to understand what we need to do deep dives on. So we do have a webinar coming up tomorrow, and it is on workforce innovation and really how do we reassign and redeploy staff as we are in the midst of this COVID-19 pandemic. We do have several webinars coming up, a lot of them based off of information that we've gotten from these clinical rounds. So we have one coming up on pathophysiology, which was specifically an area that was asked by ED nurses, so we appreciate that. We have one coming up on resiliency and what does that mean to support staff. We have one on transport, and then next week we'll have one on therapeutics, really focusing in on remdesivir and what are we learning from that. So with that, I turn it back over to you, Bruce. Thank you.
Great, thank you, Sharon. And next we're gonna transition to the AAMC Clinical Guidance Repository, and Rosha McCoy, Dr. Rosha McCoy with AAMC is here. So Rosha, go ahead, please.
Yes, thank you for the opportunity. I've been discussing the Clinical Guidance Repository, which started in early April. We've continued to add to the guidance repository. We have over 80 guidance documents and I think up to 19 different organizations guidance. We also have alignment summaries, which seem to be the most popular in terms of our website analytics. So we hope it continues to be helpful, and we continue to update and add information really for the next phase of this pandemic as well. We've added some pediatrics and some special populations. So we really appreciate everybody's interest and would love that. Thank you.
Great, thank you, Rosha. And Rick, back to you for the crowdsourcing question.
Yeah, thanks, Bruce. So today's question, and this is like for you personally, not your organization. What will you do differently that will improve your response to a COVID-19 second wave? What will you do differently that will improve your response to a COVID-19 second wave? We've learned a lot through responses for these crowdsource questions. So please don't be shy. It would be really great to hear from each of you. All right, so if the panelists, Sandy and Harry, if you could each introduce yourselves as panelists. Sandy, I'll start with you and then go to Harry.
Yeah, Sandy Schneider, I'm the Associate Executive Director for Clinical Affairs from ACEP. And I just want to mention, I put it in the chat room, we just launched a new wellness hub, which has got a ton of information for you guys who are having problems or wanting to deal with some stuff.
Thanks, Sandy. I'm going to visit the site for sure. Harry.
And hi, I'm Harry Seibold. I'm an emergency physician from Helena, Montana, and the past state EMS medical director for Montana. I sit on the EMS committee for ACEP and the community care medicine and the aeromedical committees for NAMSP.
Thank you both for joining us. And I'll now turn this over to our first speaker, Kate O'Neill, MSN, RN, Assistant Vice President for the Emergency Medicine Service Line at Northwell Health. Kate.
Thank you. Okay. Okay. Hi, good afternoon, everybody. As mentioned, my name is Kate O'Neill, Assistant Vice President for Northwell Health Emergency Medicine Service Line. I'm going to talk to you a little bit today about our experience through recovery and preparing for a second wave. So a little bit about who we are. So as you can see from the map, we are located through the New York metro area. We have 18 emergency departments in total, and it includes the full gamut of different types of EDs. We also have 52 Go Health urgent cares. We see over 850,000 ED visits a year and over 325,000 urgent care Go Health visits a year. So a large network, and we have a number of affiliations with organizations outside of our Northwell health system. And then most importantly, and pertinent to this discussion, we have over 1,000 emergency department nurses. Through this COVID experience, we became one of the new epicenters in the United States. You know, as you can see by our number of cases and number of deaths, it was, you know, we had a large impact. And included here is the breakout of the regions in which our emergency departments are located. So overall, New York had about 20% of the total US cases. We had just under 90,000 hospitalizations. And when we look at our regions where our emergency departments are located, it was 85% of all New York State cases and 90% of all New York State deaths. So it was a huge burden on our system, and then also an unsurmountable task for our staff to really respond to. And there's lasting effects of that, and I'm going to talk about that a little bit today, and what we're doing to address the lasting effects of going through an incident like such, and then also what we're doing to prepare for, you know, a potential second wave that I think we're all anticipating. So what does recovery look like? So we've really had a sustained decrease of ED volume since our volumes have settled down. You know, as we went through the peak of COVID here in our region, we were seeing primarily COVID patients. And so now really we're looking at a 40% decrease in our total ED volumes overall, and that's been sustained over the last 2 months. So you can see, you know, the hallways are empty, our trauma rooms are empty, trauma cases are down, cardiac cases, stroke cases are down 50%. And our local EMS agency, one of our local agencies in the New York area, the Fire Department of New York, they're reporting an increase of about 400% of at-home cardiac arrests. So we know that there are delayed responses for patients coming to the hospital. There is that consumer uncertainty, right? They're afraid to come. They're leaving their medical situation or their medical issues until it's a little bit too late, and when they do come in, they're critically ill. What else we're seeing is we've had a huge adoption of telehealth, right? So we've nearly doubled from this time last year. We're up at about 28% increase of telehealth visits, both post-ED care and then also primary care. And that's helping to close the gap on services that patients have not been able to pursue at a healthcare facility. And then the other piece, that we're hearing about is, about 67% of our patient population is really in fear of coming to the hospital. So that's really driving that consumer adoption of telehealth. They have a fear of getting sick if they're coming to the hospital. A nice positive to this for our staff is that our patient experience scores have actually gone up. So we're seeing an increase of our patients, being satisfied and feeling that their care that they're receiving in our emergency department is meeting their needs. And this is not too dissimilar to what we experienced in our region when we had Hurricane Sandy. So the patients that are coming, they're grateful, I think, for the risk that the staff are putting themselves through, and the care is appropriate. Additionally, we're seeing an increase in our workforce engagement. I think going through an experience like this, our staff have really bonded together. There has been more teamwork and more support for each other and their colleagues. And we're seeing that, recently we, got awarded, a number 9 ranking in the 2020 best workplaces in healthcare, according to Fortune. So, we're seeing that, but, I think the recognition by an organization like Fortune is one piece, but what we're seeing day to day from our staff and the feedback is that, they're proud to work for our organization. They're happy that they had appropriate PPE needs, and they're supporting one another. But on the contrary, what we're also seeing is that there are many unmet emotional needs from our staff. And we're seeing, this in subtle terms, right? So normally, in a normal situation, people are not so overt, but they are overt about this. And we're having multiple, debrief sessions to understand that, and I'll get into that in a little bit. But there are many unmet emotional needs because this was what one could classify as a traumatic experience. The volume of patient death and the volume of critical care patients that emergency department nurses have experienced, and the remainder of the team and our physicians, this is unlike anything that they have experienced prior. One thing that we're very happy about in our network is that we've seen a decrease in ED boarders. So ED overcrowding is not so much an issue right now. So the New York metro area has a tremendous struggle with this. Patients often board in our EDs, and our admit length of stays are twofold of what the national average usually is. So we're seeing a decrease in that, which is a nice experience for our staff after having such such large volumes of patients coming through. And coupled with this, this decrease in volume is we truly have an excess of clinical hours, both for providers and nursing and our staff. So with that 40% reduction in patients, now we have this excess, and how we manage that is very delicate, right? So, the staff, they really prefer to be at work. We're starting to see people now start to want to take time off, but they want to be at work, and they want to be there to respond if needed. So a couple things that we're doing to really aid in the recovery of our staff is addressing their wellness, their emotional wellness. So like I mentioned already, there has been, this unmet need for our staff, and we identified this very early on and started putting some, steps in place, some resources that we had existing within our system to really meet their needs. So we have a program called Team Lavender, and it's really a process and a structure and a toolkit to really support the complex emotional needs of our caregivers. And it's a program that is managed at each facility. We have a team that responds, and throughout our COVID experience, and also now that we have a little bit of time to breathe, we often will have a facilitated Team Lavender response in our EDs at shift change, or more structured in a conference room where the team really gets to sit down and debrief with each other, talk about what they've seen. Maybe depending on the group, they may say a prayer together. It's really tailored to the audience in the department or in that session, and it's been met with tremendous success, and people are very grateful for that opportunity to sit down. And during the Team Lavender, they actually hand out small sachets with lavender for people to to breathe in and smell and relax. Additionally, you can see here in the images, we have some pop-up tents, and we're calling these Zen dens. And this is, each facility has put up an area where people can come and do breathing exercises, music is played, and there's storytelling, and there's some nice giveaways for the staff. And it's really a place for them to step outside the clinical space, sit down and chat with their colleagues in a nice, safe environment, and feel hopefully a little bit more relaxed. So depending on the day and depending on the site, there's different activities and offerings through these Zen dens. Something we started very early on in our initial phases of COVID, when we were dealing with the surge of patients, is we had an expert health coach team And given the reduction of workforce in the EDs that we tried to, anybody who wasn't, clinically necessary in the ED, we removed them because we wanted to reduce not only their risk of getting exposed, but also we wanted to reduce our burn rates on PPE. So we repurposed our health coaches who, nicely had additional skills of yoga and mindfulness, breathing and meditation. And we instituted Code ITT in this together. And we offered this, you can see by the sample memo at the bottom, we offered this to all staff members. They could log in from home on their phone. They could take a few minutes and go to their car, whatever it needed. And they could take a moment, whether it be a 5 to 7 minute session or a 20 to 30 minute session, and they could really just have a moment to break away from the stress that they're experiencing. And we did this throughout our surge, and we also continue this today. Through that great experience and success of the Code ITT for our adults, there was a need to address the stress and concern for our children. And this is not the children that are our patients, but more so the children of our healthcare providers, and our staff. So we offer this every Saturday for 30 minutes, and it's a time for the kids to reset, stretch, and play, and it's a time for our staff to also connect with their children and make that time to have that mindfulness break from, the stress that our children are going through that may not be fully appreciated. In conjunction with our staff, like I mentioned, wanting to be at work and not taking that time off as we unwind from this event, there's a lot of storytelling that's happening and informal team debriefs. So our nurses and our clinicians, they felt as if they really wanted to remain in the department. They didn't want to go home. They felt they needed to be here and they needed to be there with their teams. And it's actually been quite therapeutic. So we didn't mandate people to take paid time off. We offered it, and if they wanted to, it was their decision. But we allowed them to come and experience these low volumes and be able to sit with each other and talk about what has gone on and, participate in hospital discharges. I have a little snip there. You can see we celebrate, our major milestones and discharges, having clap outs for people when they're leaving the facility, and having that excess of clinical hours has really helped to afford the team the ability to step away from the patient care area and participate in these events. Additionally, it allowed for, people to step outside the building in our urban areas and hear the clap out in New York City every night at 7 p.m. and really feel that invigoration from the community and the support that they were getting from the communities. In addition to this, our nurses were actually, a number of our nurses took a nice leadership step and started RN giving initiatives. And so they reached out to their communities. They set up, options and ability for the community to donate stuff. So we had a lot of phone charger donations that were facilitated, and our nurses were key in really providing phone chargers to family members, or to patients to connect with their family members in the emergency department, because their phone was really their only link to their family and the outside world from inside the ED. So that was very important and very rewarding for our staff. Additionally, they sought donations of tablets. We had an initiative through our patient experience team to provide iPads and tablets to each department to allow for communication with video to family members. But they also sought donations from their local communities and set them up and provided them as well. They created care kits for their patients, stuff, the little things that your family normally brings to you in the hospital, and given our restriction on visitor guidelines, taking their time and effort to create them for the patients and giving them to the patients with some toiletries, little exercise books so that they could keep themselves busy. And then additionally, there was a nice initiative around plush pillows. So, really getting donations from the community to buy a nice pillow for a patient when they're in the hospital. I think we could all appreciate that, hospital pillows are great, but they're not like your plush pillow at home. So I think these types of initiatives by our nursing team really allowed for them to give back and really fill that emotional void of patients not being able to have visitors at the bedside. That has, you know, resoundingly been one of the biggest challenges through all of this was, you know, critical patients and, you know, at the very start, even patients who were, you know, who were passing away, not being able to have their family members at their bedside was a very difficult thing for our nurses to manage. And this was a way that they felt they could give back and help fill that void. And then lastly, what we've started to see now is some people really feeling like they want to take some time off. So we're allowing our staff to use their vacation time and start to unwind as the, you know, the communities start to open up. And they can, you know, they can go away with their families or take a road trip or whatever it is that they want to do on their time off. Now that our beaches are opening and our parks are opening, they can, you know, so we're allowing more people off than we normally would. And I think now that they've had some of our formal and informal debriefing opportunities, they're feeling this sense of readiness now to step away for a little bit. So what are we doing to prepare for this second wave? And so, you know, we will see this again, we believe. What it's going to look like is still to be determined. So what we're doing across our service line is really a system-wide hot wash. So we're going, you know, we've been going through the process of facilitating structured feedback from each emergency department that's going to continue to inform our strategies about how we plan for the next wave. Additionally, we've incorporated some real-time pandemic surveillance monitoring so that, you know, we're not waiting on that first lab result to come back, or we're not waiting on that anecdotal report from our sites. We can look at the data real time and know if we're having an increase in viral related illnesses, temperatures, and admissions. So I'll just show you a snippet of what that looks like. I know it's kind of small, but so we have some dashboards. We look at viral surveillance monitoring. This looks at the, you know, a cluster of commonly associated diagnoses with, you know, respiratory pandemic illnesses compared with our historical variability by season. We also have built in a documented fever, so you can see some of our trends over the last while. So, you know, in our EMR, you know, this is where we're pulling it from, so we can look at it by month and then by day, so we can see what the variations are and know that something is starting sooner than later. And then we're also looking at our admission rate surveillance. So as you can see, there's the normal variation, and then we obviously had an increase in our admission rates through the COVID. So we will continue to monitor this real time. We don't have a data lag, so as it's occurring, we see, and these dashboards have built-in alerts to key members of our team so that we can raise the red flag sooner than later. Additionally, we are revising our ED operations. During our COVID surge, we had primarily had COVID EDs. Every patient we were seeing had a COVID concern. And we had the reverse where we were isolating our non-COVID patients. And so now how do we get back to a normal state? So every emergency department is, you know, structurally built different. So it's not a one-size-fits-all. So really taking the time with our clinical operations team within our emergency medicine service line to work with each ED leadership to really look at the physical space and, you know, work with them to determine what should be cold or our clean areas and our hot areas. Some departments are putting up temporary walls in between the two so that there is a true separation in addition to isolation rooms, because what we learned is that we never had enough isolation rooms in our EDs. I don't know if we could build enough isolation rooms in our New York metro area to accommodate the volume of patients. So how do we really create zones? And so that's an effort that's underway. How do we adapt our waiting rooms to be socially distanced, but yet, you know, accommodate appropriate patients? And then how do we additionally streamline our triage processes to reduce any upfront delays and make sure that we identify patients earlier in their walk-in so that we isolate if needed. So, you know, all of our EDs have a greeter nurse we feel very strongly that a nurse is important up front to identify that risk, and then really pull the patients in to a separate area to triage them if they are of concern. With regards to PPE supplies and competencies, we were fortunate enough to have adequate supplies. You know, we put in strategies very early on to manage our PPE supplies and our competencies. Now, as we have a decrease in our COVID-related visits, we have to continue to make sure that the nurses maintain that high level of donning and doffing competency. So given our low volume of patients, we're optimizing this time to continue to practice, competency validate our nurses, not only for PPE, but also for treatment protocols for COVID. So, during the surge of patients, everything was just-in-time education. Every day during our shift change briefs or mid-shift huddles, we would discuss a protocol change. We would discuss what proning is, the benefits of it. Sometimes you were learning it at the bedside as it was being done, and seeing the benefits before your eyes, but really learning, having time now for the nurses to really understand the treatment protocols, and then also with our pediatric population with multi-system inflammatory issues. So this is an opportune time for us to really step back, reflect on our protocols, and continue to educate our nursing team and also our physicians and ACPs, so that we all understand what we're doing the next time around, because there's many lessons learned and a lot of research that's being done here at Northwell and across the country about what works and what doesn't work. So making sure that our nurses are prepared and feeling comfortable, because half of the challenge is, when you're managing a patient and you're not fully aware of why am I doing this, and that's an uncomfortable place. But our nurses understood that we were all learning how to manage COVID patients together. Additionally, we have built in a COVID reassignment reserve process within Northwell. So just as you would sign up for the reserves for the government, we have a central, repository of staff, their clinical skills, and where they can be reassigned to, so that the next time we're faced with a surge, that this is basically just flipping the switch. We know where everybody is, and we can redeploy quicker than we redeployed the first time around. Through our learned experience, we introduced a number of clinical programs, home pulse oximetry for high-risk discharges. We discharged more patients. We discharged patients that were more complex than we ever had. And how do we, as nurses, feel comfortable discharging that patient, and also our physicians and ACPs feeling comfortable? So really hardwiring our clinical programs that we put in place. So the home pulse oximetry, the clinical callback, where we have nurses calling patients the next day and day 3 after their visits to the ED to check in and make sure that the patient is doing well, and if they need to return, helping them return to the right care location. Through all of this, our centralized transfer center was truly bolstered and got many programs up and running that we had been slowly transitioning in. We ripped the Band-Aid off and put everything in. And a key component of how we really survived our surge of patients was through load balancing of critical care patients, and then also load balancing of ED admissions. So we transferred from 2 of our most affected sites, Long Island Jewish Forest Hills, which is right near Elmhurst, which many people have heard of through the media, and then Long Island Jewish Valley Stream, which is located just on the border of South Queens and Nassau County. And those 2 emergency departments are quite small. They have about 20-something beds, in technical beds, licensed beds in each, and they transferred over just over 800 patients out of their EDs to other facilities. So really firming up our approach to how we triage those patients, and how we will continue to, maintain a high standard of transfer and through our second wave, should it occur. A last program that's very nursing centric, which we're quite proud of, is a Goals of Care program, There were many staff members who were not able to work clinically when our COVID experience started to surge up for medical reasons. And so we repurposed some of those staff members to, our physicians helped in the centralized transfer center, and then we started having questions around goals of care. It started after a very distressing afternoon in actually Long Island Jewish Forest Hills, where we intubated about 15 patients in about 2-3 hours. And remembering this is, this ED has about 20 beds, so 15 intubated patients is really not an ideal situation. And reflecting on that, we felt that we needed to do a better job with having goals of care conversations for these patients very early on. So we repurposed our nurses to work with our clinical staff that are in the ED to reach out to families and build that bridge, look for MOLST forms, and to start the conversation with the family members about what is the goal of care for their loved one. So we are continuing this program today, and we've expanded it to any patient that any of our staff members would feel that would benefit from a goal of care conversation. The physician or the ACP enters an order into our medical record that triggers a work list for these nurses who are working remotely to engage themselves in the care of that patient, connect with the physician and have a conversation about what the outlook is for the patient, and then start to do what I refer to as the legwork with connecting with the family and starting that conversation. And this is inherent conversations that a nurse has at the bedside when family members are permitted in the ED. But this, is not possible as restricted visiting. So having the nurses start that conversation, seek any forms that may be existing or any advanced directives, and then linking the family with the physician to make the official determination if there is any decision to limit the care delivery to the patient or, or place a DNR or any restrictions of care on the chart. So that has been very successful in really avoiding intubation of patients who potentially will not do well or the family member did not wish for that to occur. Secondly, we're really firming up our COVID PCR testing strategies. And this has a huge impact on EDs, in my opinion. And so our approach at this juncture, given our ability to do large volume testing within our system, is that we're testing every single admission to the hospital. We're testing most treat and release patients now at this stage, and continuing to really refine those practices and streamline the operations of getting results timely so that it can aid in the throughput of patients. We experienced medical supply shortages, I'm sure not too dissimilar to many of you. So GlideScopes, stylettes, nasogastric tubes, not too much PPE, but many supplies related to the critical care patient and the intubated patient in our EDs. So at this time, we're taking, inventory of what all of those shortages were in our EDs. And it's not necessarily that there was a true medical supplies shortage, but there's a real need to really affirm, and nursing truly drives this in our organization, is to really have a plan, if we get a resurgence and we're experiencing this volume of critical care patients again, that we have a new PAR level that we will flip to. That we will have increased frequency of delivery to our EDs, and then also an increased PAR level of these key supplies, because there was a lot of putting out fires and running for supplies that really is not necessary, that we can prevent the next time around. We're refining our surge planning, right? So any surge plan that we had on the books, that we were very proud of, and we had a surge plan and it ticked the box. By the time we looked at it, we had surpassed it. We then were redesigning surge plans at our facilities, and by the time we printed it out and disseminated it, we had exceeded our surge plan once again. And this was a huge lesson learned. So I think in general, we were not prepared for the true surge in our EDs and our critical care units. And really taking a step back now through our, hot wash and our debriefs and our new work streams that we've got running to prepare for the next time round, having a true surge plan that is really going to be effective in managing a pandemic like this is important. And I think, now that we've lived through it, we are now better educated ourselves to create a true surge plan. The next area, which kind of goes through, our surge planning and also our testing strategies, it's all linked together, is throughput. So, testing everybody, and now that we have time to breathe, coming up with appropriate strategies to manage hospital admissions is very important in the ED, very important to the ED nurse, so that we're able to timely admit these patients to hospital and be prepared for the next patient coming in. So we're working on streams with hospitals to make sure that, if somebody is a low suspicion and there's a test pending, how do we admit them to what type of unit? If their COVID PCR is negative, but they have a very high clinical suspicion, treating that patient as if they're positive, what's the right pathway for that patient to get admitted to? So really firming up all of our strategies around hospital admissions now that we have a time to step back and really breathe a little bit. The next population of patients that we continue to work through is our nursing home patients. So I think, it goes without saying that these patients were, obviously very high risk from this disease, but they were also, it's a very delicate population to manage. And so our state has actually put in some guidance and some ruling that any patient that comes to our emergency department, when they're being repatriated, whether it was for a treat and release ED visit or they were admitted to the hospital, they require COVID testing, PCR testing. And so that places a burden on the emergency department. And how do we really manage that, not only so that we can maintain our ED operations, but also so that it's the right care for that nursing home patient. Obviously, we can all appreciate that the ED is not an ideal place for an elderly patient at any stage, and we try to always limit the amount of time that our elderly patients spend in the emergency department. So really, this is an evolving step for us, but how do we manage this and how do we do the right thing by the patient and ensure that the clinical care is appropriate? So making sure that we have areas for these patients to rest in the ED if they are being discharged back to a skilled nursing facility and require that COVID result, which could take a few hours. Behavioral health patients is another special population that we are continuing to refine our practices and how we manage those patients. We require a COVID result for these patients before they can go to a behavioral health unit. So making sure that we have the appropriate, response in place for these patients, as we may see an increase in ED boarding for behavioral health patients, which also has associated risks. Making sure that we have a large tele-psych service, so making sure that our psychiatry colleagues are engaged in the care of these patients while they wait for admission to the behavioral health unit. And then another tricky patient cohort that we continue to refine our special populations, so our non-domicile patients and our prisoners that come into our EDs. And then lastly, nursing documentation. We skimmed down documentation during COVID to reduce nurse screenings that are not necessarily required during a disaster. So we're going through that and really refining it and creating a disaster electronic ED nurse note, so that if we have a situation in a pandemic where our systems are overburdened, we'll have the ability to flip to that documentation. Okay. I know I ran through a lot of information, but thank you for having me. My email is listed here. If you have any questions and you want to expand upon any of the topics that I went over, I'm happy to receive an email and respond to you.
Thanks very much, Kate, for sharing a wealth of information that I'm sure will be useful to our participants. Holly, if you could put up your slides, please. As I do that, I will, as you do that, I gotta say, I that Zen-Den is a whole lot better than any break room I ever saw. So congratulations on that one. Let's see. I'm going to turn this over to Holly Watson, MSN, RN, TNS, Director for the Emergency Department, Carle Foundation Hospital.
Oops.
Holly.
Hold on. Sorry.
That's all right. That's the way they all go like that. Not to worry, Holly. It's okay.
All right. Hello, everyone. I am Holly Watson, and I am the Emergency Department Director here at Carle Foundation Hospital in Urbana, Illinois. A little bit of professional background about myself. I have been in the Emergency Department Director role here at Carle since April of 2019. Prior to joining the team here, the entirety of my nursing career was spent in the emergency department at Barnes Jewish Hospital in St. Louis, Missouri. And I filled many roles there, from staff nurse, charge nurse, and then in leadership for many years before joining the team here at Carle. The first slide is just to kind of introduce Carle to you. This is a health system in central Illinois. We have partnered with the University of Illinois School of Medicine. And Carle Foundation Hospital is kind of like the flagship hospital of Carle Health System. We are a vertically integrated health system with over 7,000 employees. We currently have 3 hospitals, and then also the Health Alliance medical plan that partners with Carle. And we will be a 5-hospital system, I believe, on July 1st. There's a couple more hospitals joining in the system with us. So the hospital that I am the ED director of is a 433-bed hospital, level 1 trauma center, comprehensive stroke center, level 3 perinatal services. And we are truly the resource hospital in central Illinois. It's a very different setup from what I was used to from being in St. Louis, where there's many different hospitals where resources can be shared, and kind of a more leveled sharing of the patient population. Here, Carle is truly the resource in the area for all of the patients. So just to kind of introduce you to some of the first steps and challenges that we encountered, and obviously I think some of the things that I go over are going to be nearly identical to some of the things Kate talked about, and I think that it's probably that way across the country if I were to make that assumption. Obviously some of the PPE guidance, recommendations, and training, they were changing almost daily. So obviously that's going to create some confusion, maybe a little bit of frustration, and the staff were just not quite sure what information was correct, because what they had been told the last shift they worked could have looked very, very differently on the next shift that they came into work. So very carefully trying to make sure that we are being as transparent and available to answer those questions in the moment as we could was definitely one of the biggest challenges. So IDPH, the Illinois Department of Public Health, asked Carle, because of the size that we are, to be a sentinel testing site. And what that means is they wanted to see if there was a community spread of COVID before we knew that there was. So essentially, any patient who was getting a respiratory panel swab or a flu swab got an additional swab. Even if we would not have treated them as a person under investigation for COVID, the state still wanted that information and that swab sent to them just so that they could do the rule out of it. And this was in the very, very beginning, whenever there were a lot of swab and equipment shortages. So this was a very delicate balance and a lot of explanation of why are we doing multiple swabs. And it was truly with the intent of trying to get as much information as we could to see what was happening in our community. And then again, along with the sentinel testing came multiple process changes. The state and the CDC guidance on things changed, again, almost daily, of how we were going to move forward with both the regular swabbing and then the sentinel testing. And then one of the other things that we put into place, it was towards the beginning of March, was a forward triage and screening process to meet patients essentially outside of the emergency department entrance as the best that we could. And we staff that with an ED nurse because we have to be respectful of EMTALA, and we need to make sure that we're getting patients to where they need to be, while exposing the least number of people possible and getting that patient masked and in an isolated area if they needed to be there. An interesting part of this process was we built an algorithm based on what the recommendations were at the time, and as many other things changed, so did that algorithm. It changed multiple times as the community spread occurred in terms of who needed to be put into a negative pressure room. What if we didn't have a negative pressure room available? Like, how did we work through all of those processes? So this is just a slide showing you of to try to clarify for all staff and all of our clinicians, what should they be wearing and when, because it got very, very confusing, of like, do I wear an N95? Do I wear a surgical mask? I don't know what I should be wearing. And this is an example of some of the communication that our marketing team partnered with us to try to just make it as user-friendly and easy as possible for everyone, so that they would feel safe in knowing that these recommendations were the most up-to-date and current recommendations that they were supposed to be following. Another thing that we set up pretty much at the same time that we did the forward triage, we set up ED respiratory treatment unit. It's a tent essentially, but we didn't want to call it a tent, so we called it the RTU. And it was actually a 10-bed treatment space outside of the emergency department. And some of the unique challenges that presented itself with that was, how can we utilize this space while still honoring EMTALA? We were never in a situation where we needed to pursue the EMTALA waiver, just because as it happened across the country, our volume dropped drastically. So there was really no reason to go down that route. But because of this treatment unit being a part of the ED, we still have to treat those patients as emergency department patients and make sure they're getting the appropriate medical screening exam and appropriate dispositions. And then figuring out the operations of that. How does that work? So now you essentially have an outside emergency department for your respiratory symptom patients that you don't want inside the emergency department, but they're still a part of the ED. So trying to work all of those operations together and figure out, how can we provide the most appropriate care for the biggest number of people who are coming to us for treatment while exposing the least amount of staff and other patients, and still meeting all of the EMTALA requirements. Some of the things that we found worked very, very well was the use of telemedicine, because we were kind of preparing for, what if we have not a lot of providers available to take care of patients because they've been exposed and they're now on a quarantine? We're still going to have to figure out how to take care of the people coming into our department. And so we actually utilized Zoom, and we did several trials of that, and it worked very, very well to be able to make sure that that patient was getting the appropriate assessment. And then along with that, we had to work with our billing and compliance department to make sure that there were no caveats to meeting the requirements of that medical screening exam, even if it was over telemedicine. And standing up this RTU was really a great example of all the different teams coming together and collaborating to create something brand new on the spot. And it was ED nursing led the way. Our physician partners and our APPs and PAs. The registration team was hugely valuable. We had to set them up in the tent to get the patient signed in there. IT was hugely involved. We had everything we needed out there in that tent: printers, Wi-Fi, computers, scanners, anything you can think of, they had set up for us. Same thing with lab, same thing with our EVS team, figuring out how can we do this safely and make sure that the environment for our staff and for our patients is cleaned and sanitized appropriately. And then of course the emergency management team here at Carle was hugely involved. And as this evolved, Carle actually set up multiple drive-through swabbing locations, and they also stood up a COVID hotline, and that was both for employees and for people in the community. So they could call, they could give the symptoms, they could talk to a nurse, and from that phone call on the hotline, that nurse would direct them from all of the different resources at Carle of where did they need to go to get what they needed. Do they truly need to be in an emergency department, or do they really just need a swab and they can go to one of the drive-through locations? And the drive-through locations were actually fantastic because it helped conserve a significant amount of PPE. And then I just attached some pictures so that you can see it. This is the tent. And then outside the tent are some of the staff. And one thing that we quickly learned when we stood it up is you also, not only do you need a nurse and a tech inside the tent providing care to the patients, you also need someone outside of the tent to help with traffic control and wayfinding, because the local news channel came and did a story on this. And so the public saw this and they were coming immediately to the tent wanting to be seen. And so there was some in the moment education and kind of reconfiguring our plan as a whole of how can we get the patients where they need to get, because this is part of the ED and they still need to go through that screening process. And then in the bottom right, you can actually see that's where we had the telemedicine station set up for the patients. We tried to make it as private as possible, but obviously privacy in a tent can be a little bit challenging. So luckily the volume drops were significant enough that we never had probably more than 1 to 2 patients at a time in the tent. So we actually had a ton of great patient feedback in that they loved that this option was available for them. And then some of the hospital and system processes that Carle stood up, they offered online town halls with the executive leadership team for any and all staff. They had them for managers and directors and VPs. And then an hour later, they had them for any Carle employee that wanted to join in and have the opportunity to dialogue on Zoom with the leaders to ask questions. And they were as transparent as they possibly could be with what limited information that they had to provide. They also started what they called the ABCs of COVID-19 email communication, and it came out at the same time every Monday, Wednesday, and Friday from the executive leadership team. It was like a standing email agenda, I guess, of the information so that the staff knew that they could expect to get an update, or even if the update is we don't have any updates about each bucket under the world of COVID that staff were wondering about. So they sent that out 3 times a week and they continue to send that out. As I talked about before, we stood up the COVID-19 hotline. And in addition to that, they set up the online symptom checker, which actually evolved into chatbot. So instead of just doing a phone call, they could also chat with the people on the hotline about the symptoms they were having and what their next step should be. We had to stand up some pretty significant processes to support our families and visitors through this because no visitors were allowed for a while. And as Kate talked about, that proved to be very, very challenging, not only for the patients and the family, but the staff. It really wore on everybody seeing some of the patients that we had come through that were alone. And in addition to that forward triage screener, we actually added another role, and that role is a family communicator. And their one and only job is to make sure we have all of the correct patient contact information, ensure that that information gets entered into the patient's chart so the care team has the exact direct contact to the family who is needing and expecting updates on their family member while they're in the ED, and then next steps from there. And then we did set up the hospital within a hospital protections for COVID positive. We have an entire inpatient division upstairs dedicated for just our COVID positives. And then of note, something that I was like very, very impressed with, our facilities team here at Carle was able to change the airflow system in one of the pods within our emergency department. So they were able to make 16 of our rooms have a negative airflow. It's a little bit different because obviously we don't have ante rooms to go along with them. So it's not a 100% true negative pressure room, but it is appropriate to, if you need to do an aerosolizing procedure, and it is a suspected COVID or a confirmed COVID, we have many more options than we had before this started. And that is all I have. I am happy to talk about anything else or any other questions you have. My email is here if you'd like to contact me, or if you need anything else. And I appreciate being here.
Holly, thanks very much for your presentation. It's at the top of the hour. We're going to go for, excuse me, maybe 5, maybe as long as 10 minutes. I understand people have to go to lunch or they have to go to meetings and so forth. There are some polling questions I really do want to get to so people have the benefit of learning from each other. Before I do that, and Echo, be primed to do those, we'll do those in just a second. But Holly, if you'd be willing to, any take-home lessons from your experience with COVID-19? You know, 1 or 2 really big take-homes.
From personally having it, or?
You're willing to share.
Yeah. So as all of this was happening, March 27th to be exact, it was a Friday night, I came home and just started feeling really crummy. I ended up being COVID positive myself. And I was out of work. I didn't come back to work until April 22nd. And as a leader, as an emergency department nurse, that was incredibly challenging because, as you can see from the slides I presented, it was like an all hands on deck, getting the department ready, getting the staff prepared, being there just for the staff to ask questions or have those moments of vulnerability and uncertainty and help them lead forward through it. And then not being able to be there and help them with that. It was tough. It was very, it was frustrating. I felt like I was letting my team down. But I think it was a great example for everyone banded together and they got through it, taking some of the things that we had talked about before I went out sick and just continuing those on in my absence. So I think it was a really great example of, resiliency, probably is the best way to describe it, of how the staff toughed it out, even though they had those moments of fear themselves of, oh my goodness, our leader has exactly what we are preparing this entire department and hospital for. What do we do now?
Holly, thank you. It sounds to me like you're going to be teaching some courses on resiliency in the future.
Yes.
Yeah. We'll look forward to having you back. All right, we're going to do lightning rounds with polling. Amanda, if you and the team can pull it up. So I'll try to give enough time for people to respond to these, but it really helps us all learn. And so you all learn, and I hope you take home from these polling things key points that you share in the hallways and conference rooms and on the emails back and forth with your colleagues, but also so you know what happens when I see these results. These results get forwarded to the leadership of the FEMA Healthcare Resilience Task Force. Sometimes I get questions about the results. Sometimes I get phone calls or emails about, hey, what does that mean in this context? So it's truly a community of practice that we have here, spanning both the federal government and the participants on this. So with that, the first question, and those who are multitasking, get off the emails and really click on the answers for us, okay? So in the past 2 weeks, since 5/28/2020, our ED's volume has decreased, remained the same, increased, don't know, not applicable. This is pretty straightforward, should take just a couple seconds. Okay. Increased, 47%. Next. Nuance on that question. In the past 2 weeks, same time frame, RED's volume of COVID patients has decreased, remained the same, increased, don't know, not applicable. And so if you're like, don't work in the emergency department, don't know what your emergency department's doing, not applicable, that works too. So yeah, we got options here. Okay. %27 decrease. I see noddings of head in the affirmative. Okay, yeah, consistent. Next. The changes we made to our emergency department's physical space to respond to COVID-19. Hi, I'm thinking about your tents. Remain in place, continue to expand, have been discontinued. We didn't make any changes to our physical space, don't know, or not applicable. So the changes to your physical space that you made. Okay. Remain in place, 42%. I didn't know what to expect. I think I'm a little surprised. Okay. Next. Over the past 2 weeks, our ED nursing staffing numbers have increased, remained the same, decreased, don't know, not applicable. Everybody vote, please. I can't, host and panelists can't vote, but Kate and Holly, after we get done with these, 1 or 2 comments on anything you saw, okay? Okay, let's stop. Remain the same, okay. 44%, next. Today, which one of the following best characterizes your ED nursing staff and COVID-19? Preparing for a first wave, preparing for a second wave, responding, recovering, or no impact in the past, current, or future, or not applicable? I don't know how you're not applicable, but what the heck? Okay. Wow. Not a bell curve, but it's kind of like all over the map, which speaks to like, I think we're on a roller coaster rather than second waves, personal opinion. All right, next. Okay, this one we're gonna give some more time to. I almost maxed out. Apparently there's no more than 10 options, so I almost maxed this one out. Okay, which one of the following has been the most helpful to your ED nursing staff's response to COVID-19? Access to effective PPE. I threw the effective in there. I thought that was probably important. More effective clinical operations, better shift scheduling, adequate workforce numbers, availability of testing, mental health support for healthcare providers, support from my colleagues, communications from my organization's leadership, or not applicable. So I only get 1 response, so I think that one through a little bit. Okay. PPE. Just that for like reference, for those of you that hadn't been on many of these rounds before, access to effective PPE, 35%, that seems to be the highest response to this kind of question in the past. Next. I think there's a couple more. All right. Complacency, I just to frame this, the communications people, well, how are you going to frame this? So complacency has popped up as a word in these rounds, but in other settings as well around healthcare and COVID-19. So this one's trying to get at what exactly does that mean and how is that like potentially going to impact us? So the single biggest concern I have about COVID-19 complacency is inattention to my use of PPE in general, inattention to my PPE donning and doffing, I should have put specifically, inattention to others' use of PPE, inability to focus on patient care, inattention to COVID-19 protocols, lack of interest in COVID-19 training, not motivated to go to work, or the impact on mental health of myself and or coworkers. A lot of options. I would have maxed out beyond the 10, so I couldn't do any more. So let people take some time on this one. And then for those of you that really are anxious to go, what I plan on doing, I think there's 1 or 2 more, and then give Holly and Kate the last words, and then we'll be done. Or maybe they don't want to say anymore. I don't know. I'm actually very interested in seeing what the results for this one is.
Mhm.
Amanda, it's good to we're good to like see it now. I actually can't see how many of like, all right, great. Interesting. PPE and protocols looks like that. Oh, wait a minute. Inattention to others, use of PPEs in there too. I'm looking at it right along with you. I don't have any like advanced warning of these. PPE, absolutely. All right, next. This is the last one. I have a 1 week or longer vacation scheduled and plan to take in the next 3 months. Now, this one's pretty straightforward. Okay, let's see.
No. Oh.
Okay, for those that said no, y'all need to get on that. I'm absolutely serious. I am absolutely serious. Yeah,
Yeah.
that's one nursing administration ought to like take that one on.
Yeah.
Personal opinion, and I would say it for those on our ED rounds, critical care rounds, or special sessions. Anyway, we got to take care of ourselves. All right, with that, last comments. Kate, you went first, so I'm going to give you first. Last, like less than 1 minute. Yeah.
So just on those questions, I think I agree with everybody that has concern with the PPE. It's like anything, when there's a sustained heightened sense of awareness, people do get complacent and they do lose focus. And how do you really keep reinvigorating that so that it's not overbearing, but that it's effective? So I think that everybody knows their team and develop your unique strategies to address it.
Yeah, thanks, Kate. Holly.
I completely agree. All of the answers that came across on the poll, that's how I would have answered if I took the poll also. And I think the complacency of PPE as a whole is something that we are seeing and having to just gently remind. It's kind of a joke, but not really a joke, that like with the civil unrest that is happening and some of the situations in the community, it's been happening here in the Champaign-Urbana area also. And staff have felt very confused of, are we still doing COVID? Is that still a thing? I'm really confused just because of the change of operations that have happened in the ED related to the civil unrest. So I very much anticipate those answers to continue to trend for everyone.
Thanks very much, Holly. Thanks to our participants, especially the ones that are still on, the 187 still on. You were real troopers, and really appreciate you participating in the poll. And there were some surprises in there for me, for sure. And thanks very much, Harry. Hey, thanks for joining, being a panelist. Appreciate it. Holly and Kate, just great presentations. Thanks to my colleagues at Project Echo that make this really possible, and I mean that sincerely. Be careful out there. And the 57% that said no, get on the schedule request, okay? All right, with that, thanks very much. See you next week for rounds.